Bismillah ar-Rahman ar-Rahim. Today we will discuss blood pressure measurement. First of all, as we know, that pressure is the force per unit area, but this is not the case regarding the heart, which we consider it as a sphere, where whenever it contracts, it contracts tangentially, producing tension. So in this way, we can say that pressure is force per unit length. You see, so this heart is considered as if it is a sphere because it's made of two contours. So if we apply Laplace law, it will be such pressure yielding from this heart from its contraction will equal to T over R. Of course, as we know that the mechanical work of the heart is the product of the pressure and the stroke volume. It's around 1 joule. And of course, we know that the contraction of the heart makes the aorta save this energy so that it can be used during the stall to maintain the blood pressure. Of course, when the venous return is being returned to the heart, it's a muscle distant and its tension increases to increase the contraction, fulfilling what we call Starling law. Pressure in the circulation, as you can see, a patient standing, and we can figure out that the pressure at the head is around 53 millimeter mercury, of course, equals 7 kilopascal. And at the heart, level of the right atrium is as we know, 19 millimeter mercury, and at the lower limb, it's around 202. Of course, whenever I consider the difference of the pulsation from the arteries and arterioles, you can see that though the pressure is being decreased while the blood is passing through tubes, but this is not the case because the arterioles have a higher pressure than that in the arteries, and the radial artery has a high pressure than that of the aorta. So we will see it in the diagram. Of course, it's the cause, of course, is due to the elasticity and the arterial wall coat of muscles. And of course, there are different factors affecting blood pressure, as we know, the diurnal variation and anxiety and the respiratory cycle, and of course, using intermittent positive pressure ventilation. All this can affect the blood pressure. The mean blood pressure, of course, equals the peripheral resistance time the cardiac output, and the mean blood pressure equals the diastolic pulse pressure 1/3 of the pulse pressure. I'm sorry, equals the blood pressure plus 1/3 of the pulse pressure. Now, measurement of the blood pressure, of course, the simplest is the sphygmanometer cuff made of mercury. The cuff must be positioned in the center of the bladder, of course, on the medial side of the arm. The width of the cuff ought to be at 20% greater than the diameter of the arm. This is the diameter. It ought to be 20% greater than diameter. The mercury, of course, manometer must be red 0 whenever there is no measurement. Of course, it's in a straight forward position, but it can be inclined, but we ought to have a calibration regarding this inclination. Of course, partial blockage of the vent or the connecting tube can lead to varices and sluggish reading. Of course, we can use an aneroid gauge pressure to measure the blood pressure, but you ought to have a regular calibration. Of course, we increase the pressure above the systolic pressure, and then we detect the blood pressure through a simple method as the manual palpation of the radial pulse or auscultation by the stethoscope, and notifying the first sound of the cough sound. Of course, we know that are 4 or 5th sounds. The increase in the first force when the blood vessels are opened, allowing the blood to flow, it gives the first sound, and then at the second sound we have a muffling, and then so we will pass to reach the fourth sound or the phase where the diastolic pressure can be gained. Of course, there are another methods to detect this pulsations by a microphone with electronic circuitry, or we can use a pulse oximeter at the measurement site to measure the systolic, or of course we know the oscillometric system or the ultrasonic detector. Now we come to the oscillometry, which is the known one used in the theater. Of course, it's based on the von Recklinghausen oscillometric measurement, which was used in the past, where the instrument used two cuffs. Nowadays, of course, instead of these two cuffs and pillows, we use only a single cuff. And this single cuff, instead of the pillows, we have a transducer. This transducer is an piezoelectric, which is sensitized to the pressure. This pressure creates electrical waves, which is being managed. So whenever I deflate the cuff after being inflated slowly, the fluctuation in the blood vessels wall will be transmitted to the Android pressure device. So this oscillation, whenever it's in a maximal situation, it denotes the mean pressure. So by algorithm, of course, it can detect the diastole and the systolic pressure. An automated oscillometric technique, as we can see, is made of a cuff, and then we have a pressure cuff, and we have a bleed valve, and then of course the transducer, which is made of diaphragm and strain gauge, and a processor which transfers these changes in the pressure changes into electricity, which is being transmitted on an oscilloscope or a recorder, denoting the systole and the diastole and the mean pressure. Of course, as we said before, the oscillation or the maximum oscillation denotes the mean blood pressure. Of course, the blood pressure is being increased, first of all, during measurement to 160 millimeter mercury at a preset interval, or whenever it's being repeated, it's being repeated at the range of 25 millimeter mercury above the previous systolic measurement. Of course, this descent in the pressure ought to be from 2 to 3 millimeter mercury per second, and of course the maximum reading must not be more than one every 1 minute. Otherwise, the flow will be affected, and also the nerve can be affected. So this is the drawbacks of oscillometric, that affairs of course can be not used during the movement. During suppose if we want to measure the blood pressure during a patient during exercise. So this we call it are non-invasive and are not continuous blood pressure measurement device, because there is another way to measure the blood pressure in a continuous way, as we can see, the arterial applantation tonometry. Tonometry, as we can remember, the device which measures the pressure of the eye, or the volume clamp method, which will be talking about it later on, which is the Anaesth technique. Applantation, as you can see, it is a flattening of the convex surface as the cornea. You see, you flatten. You see, this is what we call applantation. I'm trying to get the next page. Other automated techniques, of course, we have a microphone, which, as we said before, which being placed on the arterial side. Of course, it's been used by the paramedical persons, where we notify the audible and audible sound and infrared sound. Or we can incorporate an ultrasonic transmitter and receiver. As we know, this change in the frequency of after transmitting through the wall of the artery will be displayed, giving a hint about the blood pressure by the Doppler change in frequency, of course, from the wall movement. The drawbacks of it, it's difficult to position the sensor. You ought to put the transmitter directly on the artery. This is the difference between it and the oscillometric technique we mentioned before. The Anaesth technique, which is, as we said before, is a volume clamped system, which we can non-invasively measure the blood pressure. The system is as like the oscillometric system, but we measure the blood pressure through the finger. So it's more comfortable to the patient because, of course, repeated measurement from the upper limb is distressful to the patient. So it is incorporating also an infrared rays. This infrared rays is specific for the artery, not for the vein. So it has a transmitter and a receiver. This is the difference between both of these regarding the dilatation of the artery in the finger. Can estimate the mean pressure, and of course, according to the algorithm present, we can measure also the diastolic and systolic pressure. So this is being placed on the screen as a plethysmograph. So this is the device which we can consider as a continuous non-invasive method to measure blood pressure. Of course, this feedback mechanism assures that the artery is not collapsed during the measurement. It is set at a preset way to keep it always dilated to preserve the plethysmograph on the screen. So this is what we call, of course, through a processor and a feedback mechanism to maintain the blood flow and not obstructing the flow during the measurement. So this is what we call the Anaesth technique. Of course, invasive blood pressure, we use, of course, mainly the radial artery or the ulnar artery or the brachial artery or the dorsalis pedis artery. But we ought to use what we call the modified Allen's test. We make the patient clench his hand in a fist, I'm sorry, and then we press with my two fingers on the ulnar artery and the radial artery, and then I release the fist, and I ought to see the flushing within 5 seconds. If no flushing occurs at this period, I can denote that there is a defect in the collaterals between the ulnar and the radial artery. Of course, after I remove the finger from my from the ulnar artery. Why? Because as if the radial artery is being thrombosed. This is why I'm keeping pressing on the radial artery. So this is the modified. Of course, I can use it on the reverse on the ulnar artery if I'm going to use the ulnar artery. The pressure in the direct blood pressure measurement is 5 millimeter mercury more than the systole, and 7 and 8 millimeter mercury lower than the indirect measurement of the blood pressure. Of course, we must use Teflon arteries, and the arteries ought to be short and with parallel sides. You see, and if I want to flush, of course, I use heparin every now and then, not saline, to flush the arterial line. Otherwise, it's going to be thrombosed. Of course, we ought not to use syringe below 5 millimeters. Otherwise, the artery can be affected, or the transducer can be affected. Of course, if we are using it for a prolonged method, we can use what we call the intraflow. This intraflow is a system where we can increase the pressure of from the figure of the Contera to 300 millimeter mercury, and we have a constriction dripper to maintain the flow by around 4 millimeter per hour to maintain the patency of the artery. The most important thing, the arterial pressure recording, as we can see from the figure later on, that we have the pulse pressure wave. This pulse pressure wave is being affected by certain items present in the system where we measure the blood pressure. That we have, of course, an amplifier during measurement, as we know, and recorder. These two are not affected much by the changes on the frequency of the movement of the fluid to and fro through the connection system. In other words, I want to say that we have what we call resonance and damping effect. Resonance is something occurring due to the change in the frequency. Of course, the pulse, the blood pressure wave from the measuring device is running in the range of from 0 to 40 hertz. What's the meaning of that? It means that it can cope with the changes of the arterial blood pressure in this range. The connection system and the transducer made of that, of course, the gauge strain and the diaphragm ought to be in a way not oscillating through and forward the sign in this range. Otherwise, it will superimpose on the arterial wave, you see. So the system, to assure that you ought to have a short rigid cannula. You had to have a short cannula and a rigid tubing system to minimize the occurring of resonance. So resonance means that there is superimposing on the pulse wave measurement. Sorry. This you ought to know: a short, wider, or stiffer caster. You see, it's so short, wider, stiffer caster to assure that there is no interference on the pulse pressure wave or superimposed. Now there come the what we call the damping. Damping is the smoothing of the pulse pressure wave. This, of course, can occur due to the air bubbles through the system or through the transducer, or occurring of a thrombus. So all these are affecting the readings. The mean blood pressure is not much affected by the damping effect. Of course, comparison between the invasive and non-invasive techniques, as you can see, of course, the accuracy of it, and can use it in a hypertensive shock patient, and there is a continuous reading, of course, more accurate in a regular pulse. That is eventually, of course, the risk of arterial damage. It's costly and it needs a skill. This is the distortion of the pulse pressure wave by the resonance, where the system is oscillating at the same range of the pulse wave measurement. This creates what we call the resonance, and this is the damping. This is the great difference, the smoothing of the reading, and comparing it with the normal pulse pressure wave from the arterial line. Venous pressure and cardiac output, or the central venous pressure, as we all know, can be measured by a stopcock or T-piece system, and the zero line of it ought to be at the mid-axillary line, which is corresponding to the right atrium. Of course, whenever we measure the pressure, we connect this system to the vein, closing the drip at that point. Of course, we can we always use the centimeter water in measurement, but we can use a transducer for continuous measurement, and noting that 1 centimeter water equals 100 Pascal. You ought to memorize this figure. Otherwise, you may make great mistakes while you are being asked regarding the systemic SI system. Venous pressure and pulmonary catheter. As you can see, the CVP is present before the right heart, and this is the lung, and this is the left heart, where we find the pulmonary artery. So we have to vessels between the before the right and before the left heart. So if, of course, the venous system gives a hint about the volume of the heart. So if we have a heart failure, right heart failure, definitely the CVP will increase. If also we have a severe lung disease, the CVP will increase, as long as there is no what we call the superior vena cava syndrome, obstructive syndrome system, which elevates the CVP pressure. This does not give a hint about the left side of the heart, because we can give much fluids, and there is if there is a left heart affection, definitely it will induce edema, though we have a normal CVP, because it does not give me a hint about the left side of the heart. Of course, if I want to measure the left side of the heart, we use the pulmonary catheter. Pulmonary catheter has a balloon. This balloon is being inflated during measurement. It is called the floating balloon, where it is being floating with the pulmonary blood reaching to one of the branches of pulmonary artery, measuring the left side of the heart, the left heart. So if I want to know anything about the left heart, I use the pulmonary catheter. And if I want to know something about the right one, I use the CVP. Of course, during introducing the pulmonary catheter, I can note the difference in the pressure during entering the chambers. As you can see, while it's entering the right ventricle, the pressure is being increased, and then it begins to be widget whenever it reaches its target. So denoting the proper position of the pulmonary catheter is by tracing the pressure. This is what we call the direct non-invasive measurement of blood pressure. You can see it is something put on the wrist. This wrist is made of a pressure transducer and a diaphragm, and there is a hydrolytic driven system made of fluid. This causes pressure on the radial artery, and the oscillation or the fluctuation of the radial artery being transmitted through this system, measuring continuous blood pressure. Of course, there is an algorithm. I'm sorry. There is an algorithm. This algorithm can measure, apart from the mean pressure, the systolic and the diastolic blood pressure. And the good thing about it, it is capable to measure the blood pressure after 12 to 15 beats. You see, so this makes it reliable to be continuous user device. You see, of course, there is also an algorithm to subtract the movements. If there is some movements in the hand and the wrist, it can, by algorithm, avoid this affection of movements on the reading. So this is a hint, a small hint. If you increase the figure, you will see that's made of a transducer and a side wall, a flexible diaphragm, and a fluid coupling medium. These things are incorporated to what we call radial artery compression device. We have, of course, we have also in the previous figure what we call the direct also continuous measurement of the arterial blood pressure invasively and through a fiber optic device. This fiber optic is made of a mirrored diaphragm. This mirrored diaphragm is being subjected to a transfer receiver and it transfer light. This inclination of the diaphragm is going to be sensed by the receiver device to measure of course, the change in the light. This is called optoelectric, which shifts the light changes due to the convexity of the diaphragm regarding the pressure into electrical signal, which is displayed on the screen. This is what we call the direct invasive measurement of the arterial blood pressure. I hope that I accomplished my mission. I hope to see you later on. والسلام عليكم ورحمة الله وبركاته.